So as mentioned, most of my research to date has been in cardiovascular rehabilitation, and the first part of my presentation today will be my PhD research, and time permitting, I'll present some data from a recent study that we've conducted that isn't yet published. So for those that aren't too familiar with this, I'll give you a little bit of a background so that you understand the context of what I do and why I do it. So in 2022, approximately 1 in 10 people had hypertension in Australia, and 1 in 20 had heart, stroke, or vascular disease. And ischemic heart disease was the #1 leading cause of death, and cardiovascular disease was the #1 cause of disease burden or disability in 2023. So cardiac rehabilitation is recommended for pretty much anyone that has had a cardiovascular event. So coronary artery disease, myocardial infarction or angina, stents or surgeries, valve repairs, replacements, bypass grafts, heart failure. Although heart failure tend to have their own rehabilitation stream, so that's not going to be a focus of my presentation today. And then things like implanted cardioverters, defibrillators, that sort of thing as well. So these are the aerobic guidelines from the National Heart Foundation. So these are the ideal. And as we know, most cardiovascular clients cannot achieve the ideal. It's very much a work towards. So 4 to 6 days a week, and RPE is more commonly used than the VO2 max. Most cardiac rehabilitation programs are about 50 to 60 minutes in duration, and it really depends on what they've been referred for. So in most instances, they'll recommend that aerobic training is performed for 4 to 6 weeks prior to any resistance training. So most people won't really perform any sort of resistance training. But one thing to note here is that VO2 max testing isn't done in this population in the majority of hospital settings and private practice. So this guideline just isn't adhered to in Australia, even for people that are on a beta blocker. Also, heart rate reserve is a better indicator of VO2 reserve, not VO2 max, but these are the guidelines that are available for clinicians. So it is confusing to people, and that's where they tend to go ultra conservative and just say, all right, we want you to work between an RPE range of most 12 to 13. They don't go as high as 16 on the RPE scale. So therefore, whenever they ask a patient what their rating of perceived exertion is, they'll give them what they've been told they should be working at. So it's not really indicative of intensity in this population. And then in terms of resistance training guidelines, these, by the way, are the ones that have just been updated, both aerobic and resistance. So they've now said essentially 1 set as a minimum of 8 to 10 exercises, and look at building muscular endurance before building muscle mass. So they're quite broad, and they don't actually consider the surgical or cardiac procedure that patients have had in terms of the guidelines. And the recommendation through Australia now is 1 to 2 weeks of aerobic training prior to commencing any resistance training. So in terms of the median sternotomy procedure itself, so for individuals with extensive multi-vessel coronary artery disease, a CABG or a coronary artery bypass graft is what's recommended, and median sternotomy remains the gold standard for access to the heart for CABGs and then valve repairs and replacements as well. So despite it being the gold standard, it is also the most invasive procedure that a patient can undergo. So an incision is made down the midline of the sternum, and that divides the subcutaneous tissue and the pectoral, the fascia of the pec major. And then what they do is they use a bone saw to make the osteotomy down the middle of the sternum. They'll clip the transverse venous arch to try to limit any excessive bleeding. They'll then make an incision to the intraclavicular ligament, and then the sternoclavicular ligament is dissected from the sternum along with the diaphragm. So there's quite a bit of trauma to the chest itself, and that's before they've even opened it up, which is the next procedure. They do the retraction. If they do that too quickly, the innominate vein, the brachial plexus or costovertebral joint can be impacted, and so injury can occur to that, which then again impacts their recovery and rehabilitation further. The conduits are harvested from the internal mammary artery, the radial artery, or the saphenous vein in the leg. So again, it's not just an incision to the chest. There are other wound sites to consider with exercise prescription as well. And following the procedure, the sternum is then closed using wires, cables, or a plate cable mechanism like the Sternalock. And that essentially involves them screwing plates into the sternum, and then a cable goes underneath and wraps around to try to minimize movement further. That's so far, based on what's available, the best way to close the sternum, because it brings the sternum a lot closer together, but it minimizes movement a lot more than the other mechanisms. But it costs about $80,000. So that's where private health insurance is extremely beneficial, because it's just better in terms of recovery and people returning to function a lot quicker. So once all of that is done, that's anywhere between 4 to 8 hours usually. The time depends on how much needs to be done and what other procedures need to be done as well. So it's a lot of time under anesthesia and a lot of time with someone's hands inside your chest. So understandably, people are quite sore and out of it for quite a little bit until all of the good post-operative medication wears off. So, following surgery, patients are told to avoid carrying weights more than 5 kilograms, heavy manual tasks like sweeping or changing the bed. So, a lot of ADLs are out, and they can't do any exercise with weights. So, already there's a contradiction between being told that they can't carry more than 5 kilos, and then the guidelines are currently for exercise, don't do more than 1 kilogram bilaterally. So that's more than what a bottle of milk is. It's more than what the fridge door weighs. So all of a sudden you've got people that are told that they essentially can't use their arms, and they take that quite literally. And then that's when obviously further deconditioning occurs. So these general precautions were based on early cadaver studies where, for obvious reasons, bone healing couldn't occur. And they also used the wire as the sternal closure mechanism. And there's nothing wrong with that. It's still the most widely used method of sternal closure. But at the same time, if your cadaver's not healing, how are you going to expect there to be any calcification and therefore determine how much movement will continue to occur with recovery? So the contradiction of guidelines, and then there's just a general lack of evidence in terms of resistance training, does make it really difficult for clinicians to implement it and to implement it properly. So therefore, often patient recovery is delayed even further as a result of the post-op deconditioning. So The necessity of these surgeries often indicates a significance of chronic vascular disease, and with that impaired blood flow to the brain and working muscles, which results in deconditioning pre-operatively. And patients undergoing these procedures are typically elderly with multiple comorbidities, so not the most active to start with, and 30 to 50% of them have evidence of pre-operative cognitive impairment. And the cognitive impairment here was key for us as one of the studies, because those that experience post-operative cognitive impairment are 7.5 times more likely to advance to Alzheimer's disease within 10 years post-operatively. So that's why we looked at this as one of the main outcomes of one of the studies that we'll discuss. And the reason why resistance training was such a focus for us is because it's been postulated that resistance training improves the neurotrophic factor pathways that are associated with cognitive decline and sarcopenia, which is also common in older adults. So the fact that they're having to learn a new skill and practice that is said to improve the neuromuscular activation and input from all areas of the brain, and then that results in greater executive functioning, which helps in their recovery in the long term. So this was some of the results from one of my first systematic review. So we wanted to look at what is actually done in cardiac rehabilitation in terms of what the literature says versus do they actually meet the guidelines that are available in Australia, the United States, and the European guidelines as well. So based on the current literature and recommendations, we know that cardiac rehabilitation doesn't typically involve resistance training, or not resistance training by its truest definition. The studies that involve median sternotomy populations, they typically are looking at thrice weekly sessions and a 12-week program. The sessions usually last for 60 minutes per session, and all of the studies included moderate, or reported pretty much a moderate intensity RPE, but they also said that they performed both aerobic and resistance training. So really it was a range of light to moderate intensity. And then when we conducted another systematic review to look at what resistance training was actually done, it turns out that most studies class body weight exercises or calisthenics, which is essentially that when you look at it in detail, they were just working through an active range of motion of the upper limbs. So there was no added weight to it. And yet after 6 to 8 weeks of that, they're like, oh, you're normal again. And that's where the issue lies. And for one patient of mine in particular, during one of the studies, he was in the control group, so didn't receive any information. And then I had a follow-up with him at the 6-month mark, and I said, oh, how's it all going? And he'd been doing really well. And he was like, oh, not so good. And I said, why? 70-year-old man got told that he was all right and he'd healed and he could go and do anything, and he decided that he'd just walk into a gym near his men's shed and try and lift a 20-kilo weight because he was told that he could do anything, and he ended up needing a reclosure because he busted his chest open again. So there's no education for them either around how to safely progress. And if you've got a 7-year-old that, in his own words, had not lifted weights in more than 20 years, you all of a sudden can't go back in to do that, yet he didn't seem to understand that it wasn't physically possible because you can do anything. You've got a brand new heart or a new engine. And that's where a lot of the education comes into it that just is lacking. So the other important thing to note here is that none of these studies actually met the Australian, American, or European guidelines. So the guidelines in themselves are quite conservative, and then our research is even more conservative again. And then they wonder why the results of these studies aren't as good as what they could be. So as part of it, we looked at the fact that, came out that we know that the addition of resistance training to standard care, which is typically aerobic in nature, and also includes breathing exercises and some stretching, leads to superior improvements in cardiopulmonary capacity in this population compared to just standard care alone. So there is a benefit of adding resistance training. And furthermore, the improvements in cardiopulmonary capacity are comparable between aerobic training and resistance training when they're performed in isolation. So some clinicians will argue that resistance training doesn't do anything to improve cardiopulmonary capacity. Given that it's similar, obviously combining them both at the same time will add in a greater benefit, but it also has benefit for return to function and maintenance of independence and ADLs. So the lack of consensus between sternal precautions, cardiac rehabilitation guidelines, and emerging evidence is problematic for clinicians who are required to deliver exercise-based interventions and have them as evidence-based interventions. So due to the benefits of resistance training and its underutilization or incorrect implementation, that was why we conducted the SAFE Arm study, looking at the safety and feasibility of early resistance training after a median sternotomy, and hence the SAFE Arms. So this was a multi-centre prospective pragmatic pilot RCT, and data collection was performed at the Royal Melbourne and Melbourne Private Hospitals, and then also at Keeser, Essendon and Caulfield. So we used their site once patients had been discharged from hospital for all of our post-discharge assessments and the exercise interventions. And the people involved were adults greater than 18 years of age, undergoing their first elective cardiac surgery via a median sternotomy. And then they also had to reside within like a 5-kilometre radius of the site, just because we found that those that lived further, because they can't drive for at least 4 weeks post-operatively, that would inhibit them from starting the intervention 2 weeks post-op. And in Melbourne, driving 10 kilometres can take quite a long time compared to the country. So that's why we limited it, because then we were able to also provide transport in terms of taxi vouchers to help try to facilitate attendance. So we used ultrasound to capture motion at the sternal edges, at rest, during a cough, and then during the 6 exercises listed. And we looked at this 2 weeks, 8 weeks and 14 weeks post-operatively. So hopefully I'll get the video going. So this was one of the participants performing a bicep curl, and then we were just looking at movement between the sternal edges during that. So we look at the 2 sternal edges. If it was overlap, we looked at the total distance moved. If they had sternal separation to begin with, we just wanted to make sure that that didn't increase beyond 2 millimetres or result in any increase in sternal pain, which would indicate that the movement was unsafe for them. So we looked at the mid and lower sternum for that as well, because we know that greater movement occurs at the lower sternum towards the xiphoid process. So of the 20 participants that were randomised to the resistance training group, we ended up with 12 complete data sets, and the mean age of participants was 71.3 years. Most of the cohort were male. Obesity and type 2 diabetes were the most prevalent comorbidities. And then the resistance training intervention was commenced 14.5 days on average after surgery. So a lot earlier than the 6 to 12 weeks that is currently recommended. So most places will wait until after 12 weeks because they just assume that the sternum is healed within a 3-month period, and then that's when they'll start to introduce weights above 1 kilo. So the following 4 slides will depict the median sternal micromotion for each activity, as well as the minimum and maximum movement. And you'll notice that no participant exceeded 2 millimeters of sternal micromotion for any of the 6 upper limb exercises, which is what's deemed safe in the literature for bone healing. The cough, however, did. And if anyone has worked with this population before, coughing is promoted on day 1. So although it results in the most shear force to the sternum, they're still getting them to do it for lung clearance. So if they can do that, they should be able to do weights as well. So for lateral micromotion at the mid-sternum, which was 6 centimeters from the sternal notch, the exercises for the highest median movement were the shoulder press at 2 weeks, the seated row at 8 weeks, and the bicep curl at 14 weeks. But again, still less than 2 millimeters overall. At the lower sternum, which was 10 centimeters from the sternal notch, the greatest median lateral micromotion was the bicep curl at 2 and 14 weeks and the tricep dip at 8 weeks. In terms of anterior-posterior motion, so forward and back, the mid-sternum, highest median anterior-posterior movement was the tricep dip at 2 weeks, the seated row at 8 weeks, and the shoulder pull down at 14 weeks. And at 8 weeks, the greatest median movement was actually a reduction in sternal separation from rest, which occurred during the seated row. So it essentially just means that the bone moved closer together rather than further apart on average. At the lower sternum, we had the shoulder press at 2 weeks and the tricep dip at 8 and 14 weeks, respectively. So at 2 weeks post-operatively, all participants completed the first 6 exercises with a minimum weight of 20 pounds, which is about 9 kilograms. Because Kiesa is a European concept, all of their equipment is in pounds as opposed to kilos. And the lowest amount of reps that they were able to complete were 10 repetitions. And we wanted them to ideally get between 10 to 12 repetitions to know that they were working at a moderate intensity. And at the subsequent time points, the greatest increases in mean weight lifted occurred with the triceps dip at 8 weeks and the shoulder pull down at 14 weeks, with patients completing 12 repetitions at an average of 36.8 and 41.2 kilograms respectively. So already weights far exceeding what they would normally be able to use within that time frame in cardiac rehabilitation. So exercises were progressed provided that there was no evidence of an increase in sternal separation using the sternal instability scale, which is a manual palpation technique during the exercise program, and then also 2 millimeters using the ultrasound, and then no increase in sternal pain during the performance of these exercises compared to rest either. So it's important to note that there was no increase in participant-reported sternal pain during the 12 weeks that we had them either. With any of the upper limb exercises, they still did report it with a cough, even at the 6-month mark. So because this is a new concept in terms of measuring ultrasound whilst exercising, we conducted an intra and inter-rater reliability, and 80 images were selected at random and assessed twice by 2 different assessors a month apart, just to look for any consistencies. And according to the KU classification criteria, the intra-class correlation coefficient for inter-rater reliability for both lateral and anterior posterior micromotion was moderate to good, and intra-rater reliability varied between moderate to excellent between the 2 raters. So we had one that was more experienced in ultrasound and one that was a novice, and the novice was the moderate reliability. So it goes to show that even with minimal experience, it's still a relatively reliable measure, which is positive for new clinicians to know that they can't do anything too bad if they follow the procedures. So the second study, now that we established the safety of the resistance training, was looking at the effects of an early 12-week resistance training program performed at a moderate intensity on post-op cognitive recovery compared to standard post-op care, which is predominantly the aerobic-based intervention. So all participants received standard post-op inpatient treatment whilst they were in the hospital, and upon discharges when they were randomised to either the aerobic-based rehabilitation group, who undertook a once-weekly program for 6 weeks, and it was 3 hours per session, and that was predominantly light intensity aerobic exercise in conjunction with some education sessions, and their intervention was commenced anywhere from 2 weeks to 3 weeks to 2 months post-operatively, and the variation there is because the referral for cardiac rehabilitation, and by the time they have space in a program, differs between rehabilitation sites. Whereas participants randomised to the resistance training group undertook a twice-weekly 12-week whole-body resistance training program, and they performed a single set to volitional fatigue for each exercise, which was typically between 10 to 15 reps starting at that base resistance of 9 kilos, and this intervention was what we commenced 2 weeks post-op. So our primary outcomes were the Alzheimer's disease assessment scale and cognitive subscale of the ADAS-COG. And as you can see, there were a lot of secondary measures. So participants were tested pre-surgery at 14 weeks and 6 months post-op for their primary outcome measure. And as it was a pilot, we only performed analysis for statistical significance on the primary outcome rather than the secondary as well. Individuals with Alzheimer's disease need an improvement of at least 4 points to be deemed a positive response to any clinical trials, ranging from 12 to 24 months. So because we only had a 6-month intervention, we were looking at a 2-point increase over the study period, which we deemed a significant change in cognition from baseline. So being a pilot study, again, we didn't do a sample size calculation. However, there were 20 participants in each group that was deemed feasible for the 2 training facilities, as we only had 1 person running the interventions and doing recruitment, and that was me. So a total of 733 patients were screened, 39 consented to participate, 1 was deemed too medically unstable to even have surgery in the end. 20 participants were in the resistance training group, 4 withdrew following randomisation but prior to commencing the intervention, and another 2 withdrew after the intervention had commenced. 1 was told by the hospital that education was essential and they wouldn't get any benefit from participating, so they were scared about not receiving any education sessions, so left, and the other one moved out of the area, so it was going to be too far for him to commute. And 1 person out of the standard care intervention withdrew prior to commencement as well. The resistance and aerobic training groups' baseline demographics were comparable, and participants in the resistance training group were typically younger, male, had a smoking history, and consumed more alcohol each week. So despite the fact that they were younger, their health was actually worse than the control. The primary outcome of ADAS-COG is scored out of 70 points, with higher values indicating greater cognitive impairment. So the results of this study showed that there was a significant interaction between groups over time favouring resistance training, and the resistance group also showed evidence of improvement in scores over time, whereas the aerobic group showed deterioration. And there was a significant difference in the change from baseline at 14 weeks between groups, but not at 6 months. At 14 weeks, none of the resistance training group had declined in their cognitive scores by 2 points or more, and 5 patients had already improved by that value, indicating that patients had returned to their baseline cognitive function or better, whereas in the aerobic-based group, 9 patients had declined compared to their baseline levels and 2 had improved. At 6 months, 3 patients had declined and 8 improved in the resistance group, while 7 had declined and 4 had improved in the aerobic-based group. As this was a pilot study, our other outcomes of particular interest were the safety and feasibility of the study. There was no pain reported during the resistance training sessions, and all patients had a clinically stable sternum at 6 months, as assessed by the sternal instability scale. And in terms of feasibility, there were far fewer patients who met the eligibility criteria than we anticipated. And one of the main reasons for that is that cardiothoracic surgeries aren't performed in Tasmania. So all the Tasmanian patients would come to the Royal Melbourne or Melbourne Private for surgery. So obviously that automatically excluded them. And then there's a lot of country people that travel to those locations for surgery as well, which again automatically excluded them. So the recruitment rate was much slower than what we had anticipated. We were expecting 2 to 3 patients per week per site, and that just wasn't the case. And then attendance, despite all that, attendance at the resistance training sessions was actually quite high. So we had 93% attendance from those participants, which indicates that it was well tolerated. So similar to the ADAS COG results, we did a mini mental state examination, and we could see that the resistance training group had returned to their baseline levels by 14 weeks, whereas the aerobic-based group hadn't. The scoring of the ADAS COG may mean that it's a bit more sensitive than the mini mental state to detect changes in cognition, particularly in the short term. As we expected, with upper limb function and lung function, it decreased 2 weeks post-op. And that was demonstrated by the functional difficulties questionnaire, forced vital capacity, and forced expiratory volume results. And whilst lung function had not quite returned to baseline levels by 6 months in the resistance training group, it had actually improved in the aerobic group. So there's still a benefit of performing aerobic training in this population. We're not saying don't exclude it completely. And then the other thing that we looked at was dynamic balance. So that was assessed via a 4-square step test, and dynamic balance improved from an average of 11.72 seconds 2 weeks post-op to 8.94 seconds 6 months post-operatively in the resistance training group. And that was compared to the aerobic training group, 9.48 seconds, and the greatest improvement was at 14 weeks, compared to the 11.76 at baseline. For all 3 strength measures, the resistance training group achieved their maximum results 6 months post-op, so their strength continued to improve even after the resistance training program had ceased, whereas the aerobic training group achieved their peak at 14 weeks, and it sort of plateaued between the next assessment at 6 months. There was no change in weight or BMI for either group. However, there was a slight increase in waist circumference, a slight decrease in waist circumference rather in the resistance training group over the 6 months, but no change in the aerobic group. So these 2 studies were the first to examine the effects of upper limb resistance training implemented early within the post-operative period, and looking at micromotion of the sternum using loads that exceeded those required to perform many activities of daily living and exceeding those in the current guidelines. So we found that bilateral machine-based upper limb resistance exercises performed as early as 2 weeks following median sternotomy were safe and feasible following cardiac surgery, and provided they were performed within the safe limits of pain and discomfort. I've also highlighted the following sternal precautions as when looking at the exercises performed in the study that we did versus activities of daily living. You'll see that the greatest weight and force to perform them were far exceeded by our study, which means that people should be able to return to their ADLs without much issue as well, which means that we shouldn't be encouraging people to not use their upper limbs at all. So the weight ranges in this study were what we should be aiming towards, but obviously won't be done by a lot of cardiac rehab facilities in terms of stage 2 rehabilitation, primarily due to a limitation in equipment. And that was one of the main limitations of our study. We use CAM-based machines, and the expense of those is not what hospitals can afford. So that's why future research will look at the use of free weights and TheraBands to make it more accessible to people as well. So furthermore, undertaking early resistance training appears to accelerate cognitive recovery following cardiac surgery, with results indicating that improvement in cognitive function is maintained 6 months post. And previous research has found that post-op cognitive impairment can persist for several months following cardiac surgery, which was synonymous with our findings of the aerobic-based group. And I won't go into the other one because it took longer than I expected. So, any questions?
I have one, Jacqui.
Yeah.
So you did your study, that's 2020, you published that?
Yeah, 2022. 2022 it got published, and that's when I finished my PhD.
Has there been any change to guidelines as a result of?
The ones that I showed at the start in terms of not implementing resistance training until 1 to 2 weeks of aerobic training has started is the most up-to-date guidelines, and now they have used the ones that as a minimum and working on the high repetition range before progressing to building muscle mass. So that's the only change in guidelines, but again, more generic and not specific to the sternotomy population. So the main recommendation from ours was that clinicians should be assessing sternal instability in order to inform whether or not they commence resistance training and how they progress it. So it's not good enough to just assess it and go, well, you have a clinically stable sternum before we start. Here, I'll give you this weight, but then next week we increase it because you're reporting it's easy, and then you revert back because you do an injury. So that was the main recommendation of ours, and there is an algorithm that's available, but again, it's not common practice for phase 2 sites to do it. And that's mainly because clinicians don't have experience with assessing the sternum. It's just not something that they're taught at uni. And then because they are in a group class, they could have 20 people in that class and they can't watch everyone at the same time. So they're just like, oh, here, everyone use a yellow TheraBand because we know that you're going to be okay, pretty much, which makes it difficult. So there's a lot more progress overseas than what there is in Australia. Yes, indeed.
Can I just follow up on that? Why do you think that is? Why is there more progress overseas than, say, in Australia? We've done, like, way back before I was here and in the UK, we did like big sort of intervention study with Huntington's disease. So pretty much similar things to you included in your like review of the exercise prescription. And a lot of them are concluding that, say, resistance training and aerobic training in Huntington's disease wasn't useful, and then you go back and you look at the exercise protocol and you're like, yeah, that one,
Yeah,
you know, it's fine, do a bit of stretching, you know, watch TV and move a bit, that kind of thing. So there was a real lack of actually any kind of framework or guidelines around what needs to be done. And there'd be the thinking on like, why is that the case? Why is it the say even in cardiac rehab, obviously, you know, exercise is super important and everything. So why is it then that say clinicians are reasonably unfamiliar with it? And got my own personal experience with like mum of like, you know, end up sort of they should be doing something, but there's nothing prescribed and there's no referral on to that. So why, you know, what are the barriers to actually making that exercise aspect like implementing it more effectively?
funding is definitely one of them. So currently there's no like Medicare funding to attend cardiac rehabilitation. So beyond a phase 2 program, people just don't attend. Attendance rates are also terrible. Everyone is supposed to be referred, yet attendance and completion is like 10% of those, which makes sense when you look at our low recruitment as well, is that despite being referred, people just don't go because they don't see the benefit in it. Like I had a number of people that I'd go in to try to recruit and they just didn't understand the procedure. I'm like, you would have watched a video, you would have done this. And they're like, oh no, I should just be able to go on holidays the week after overseas. And I'm like, no, like this is what's going to happen. And they're like, oh, it's going to take me more than a week to recover. I'm like, yeah, you're not going to be able to return to work for this period. So I think funding is one of the big issues.
Sorry to jump in there.
Yeah.
Is the other one like health literacy based?
Some of it is, so often we try to target it at a grade 3 level, just because we have such diversity in terms of migrants coming in, but also like ATSI population. And a lot of them don't quite understand the importance of it, which we see in terms of their risk factors as well. They don't understand what their risk factors are and what behaviours have essentially led them to have quite significant coronary artery disease. So therefore they don't understand the surgery, they don't understand the rehabilitation, and they don't have a cardiac rehab person come in to see them in all of their pre-op screening. They only have the surgical registrar and the anaesthetist registrar come in. So they're not explaining that part to them. They don't know what happens after. Whereas in the States, like one of the groups out of Texas, they have an entire like unit within a hospital that is massively funded to do this. So they have people that they're returning to powerlifting and that sort of thing. But they're all case studies. They're not doing it as an entire group because that's not what the majority of this population are sort of going towards. So they have the funding and the support from the hospitals, whereas we don't. In the public system, the referral is to get them through to their own cardiac programs because then they can justify continued funding for those staff members. So there's a reluctance to have them involved in any research projects that would detract from that. And the private setting is the same. They're relying on your private health insurers to fund those people and then to get them to come in for this from like an ongoing inpatient and then phase 2. So they're reliant on them to come through the doors. So again, then they don't want to do anything that is going to upset the status quo. And they don't tend to see people one-on-one. And when you're looking at some of the more advanced people that have had cardiac conditions and are wanting to return to a higher level of training, their needs just aren't met and they don't really care because they don't form the majority.
Is that same in Europe as well?
Europe is very similar, I think. I had someone recently wanting to return to powerlifting contact me saying, read your research and I found this other study. I'm like, it was like a case control study. It was only one person. Let's not jump to conclusions about what was done here. But he was in the UK and he's like, well, who could I get? I don't know the UK system as well, but it took me a while. Like I pretty much spent an entire day trying to figure out who delivers their cardiac rehab, who can do that once he'd been discharged, and find people to refer him to, because what he needed was a little bit of both S&C and the cardiac side of things. So we needed someone with an understanding of both, but it does not many people under.
My experience obviously work systems, weights, etc. I think the health system is worse than I was to like exercise rehabilitation. They don't have AEPs, for example, and that's one of the bring the Australians.
Yeah. He'd said, I think he was a private health, but he said like his insurer wouldn't allow him to have scans done, like an X-ray or a CT, to look at whether or not he had sternal consolidation at 3 months or 6 months post-operatively. He said if it's not clinically relevant, it won't be deemed necessary. And I'm like, the only way it will be deemed clinically necessary is if you report having pain in your chest with movement and that it's increasing. So the only way you're going to get what you want is pretty much if you lie to get that to happen so that the insurer will fund it. So that was just his perspective, which is only what I've looked into within the last couple of months when he contacted me. So a very different situation. And it tends to be those that can afford it will go down that pathway. Like I've had a runner come to me wanting ECG while he ran on a treadmill and was prepared to pay $150 a session for me to just put an ECG on and stand there and watch him, even though that I knew he was fine because he was just doing the same thing he'd done every week, but he wanted to pay it for that reassurance. Okay. Yeah.
Say when you're wrong.
Thank
All
you.
right, thanks very much.
No worries.
Yeah, really interesting research. Commenting on Europe, I think in Germany,
Yeah, I think it's a lot better in Germany. They have pretty good health compared to most. Yeah.
But those who are in, they get weeks, and then you have full on strength and conditioning next. With,
Yeah.
which is also paid for. So it's quite good when they invest in what network. They had heaps of funding for research. And
Yeah.
Occasionally, even at little ECGs that patients could take on with them just to wear safe.
Yeah.
And they were monitored with AI, but at least to get them to engage with any type of exercise. I had one question, and it's probably time-wise wasn't in there. You had a lot of secondary aims in your second study.
Yeah.
Have you looked at general changes in their lifestyle that also contributed to the findings? Because for a lot of chronic patients, if that happens, then they start thinking about their habits and what they do.
Yeah, we didn't look at it as part of that study, but this is what we looked at for the cardiac population more broadly for this one. And we found that it was because it was all self-reported, we couldn't actually monitor it through observation, that their physical activity behaviors, they reported like a 4 times increase from baseline. So they went from performing about 1,500 minutes per week of moderate to vigorous physical activity to reporting like 8,000 minutes. I'm like, something doesn't add up here. They had an increase in their 6-minute walk test distance, which would a significant increase, which would indicate that their cardiorespiratory fitness had continued to improve, but maybe not to the extent that they were reporting that they were all of a sudden extremely active. I'm like, oh, if you're doing 8,000 minutes a week, how does that work out? And granted, vigorous is double the minutes of moderate. It was something that they just couldn't understand. But again, it was, I'm extremely active in my work. I'm like, what do you do for work? But I had one guy that all of a sudden reported this massive increase, and he's like, oh, I do get caught up in my hobbies though. I'm like, what's your hobby? And he's like, oh, you're gonna laugh. It's searching anime online. I'm like, oh yeah. He gets into a rut and will spend 16 plus hours. He will lose days in front of his computer. And I'm like, how are you telling me that you're vigorously active during that period? So like there is still a, yeah, his heart rate might go up, but yeah, there's still a disconnect between what's being reported versus like what they're doing. But there's definitely benefit to the education side of things, but in terms of most of ours returning to exercise, like the findings of this one was that they need more individually tailored programs. So instead of just discharging them and assessing how effective the program was, maybe have a one-on-one following that where they get a new program of where to progress to, particularly if they're not sent on to a phase 3 or a phase 4 program where they are confident to self-manage. They can promote that, whereas it just doesn't happen. So therefore, most people don't do anything.
Is there like a decision algorithm that's been developed where
There's not too many phase 3 or phase 4 programs in Australia. They just started to get rid of them again because of funding. So a lot of the community rehab centres would have to run phase 3, or they just have like an open gym session where they can essentially come in and the patients are just taking themselves through it, but at a designated time. Yeah, it all comes down to funding and what people are prepared to pay for. So we do get some that are wanting to pay, but private health insurance is a big barrier for us as well. So like the public hospitals have to have a certain number of clinicians that they see. They can't see an EP and a physio at the same time because they class them as being the same. So like one might do hydrotherapy, one might do a gym-based session, but that has to be on the same day. They can't do it on separate days. So if you've got these people that are quite deconditioned and haven't exercised before, and all of a sudden they're spending 3 hours a day when they come in as an outpatient, they're not ready for that. It's just too much too soon. So there's not a lot of progression in terms of their exercise. Whereas the public system, they'll see them once or twice, if that, and then they're expected to complete a walking program, but they get no guidance on that walking program, and there's no assessment of whether they're even safe to do that unsupervised. And as we know, with accessibility of footpaths and things, not everyone has a flat, even surface that they can walk on, yet they're often cognitively impaired, they have mobility issues, they're reliant on like a 4-wheel walker, and then we're going, oh, we'll just go and walk for 50, 60 minutes and gradually add a day each time. It's just not feasible. So yeah, what we're doing it's fine. It improves their health, but we know that any exercise will improve health. So to go from nothing to something that's better, but we're still not doing the best that we can. Right. Thank you. Is there anyone online have a question? No one has a hand up, so I'm going to assume that that's a no. All right. Thank you, everyone.
Yeah,